Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone, we're going to start our mock discussion. Inshallah, we are going to talk about antepartum hemorrhage. Very, very, very important module in your exam. Antepartum hemorrhage, postpartum hemorrhage, gynecological causes of hemorrhage. This is our practice. This is our practice. So when you find like 5 or more questions about hemorrhage, this is typically normal, or maybe more. So I'm going to start with some epidemiological questions. It's not my favorite, and I know it's not your favorite also, but it's still in our exam, part of the curriculum. We have to answer epidemiological questions. So placental abruption is seen more often in all of the following conditions, except I need your participation, guys. Try to be active and try to answer even it's wrong. Even it's wrong. Spell out what's in your mind. Okay, placental abruption can be seen, of course, with chorioamnionitis. So he wants except, by the way. He wants except. We can see it with chorioamnionitis, yes, of course. With twins, yes, of course. With preeclampsia, sure. With trauma, very common. The only one which is not common to be seen is prima gravida. It's not a cause for placental abruption. Sorry. This is why I told you my keyboard is going insane. Okay. The incidence of low-lying placenta in second trimester ultrasound is as high as, this is very important. If it comes in the exam, I won't blame them. This is a piece of information that every obstetrician should know, because this is what you are going to tell your patient in her normal mid-trimester ultrasound scan. When she's having a low-lying placenta, are you going to tell her this is common or uncommon? Excellent, everyone. Up to 25 or exactly 26%. So this is common or uncommon? Common, of course. If it's more than from 1 to 10 to 1 in 100, this is common. when it's rare, the percentage of rare. One in 1,000 to 1 in 10,000. Excellent. Excellent. This is of extreme importance. Okay, I'm not going to ask you to memorize every digit in the word, but when when it has something to do with antenatal care counseling or a complication counseling, you should know it. And we have a very recent file about the important figures in obstetrics. Please try to review it. I think I have shared in the general group for September candidates. Okay, this one. What is the risk of emergency hysterectomy in a woman with placenta previa? But take care. She has been admitted for cesarean section, and she is multiparous, and she has a previous history of cesarean section. So what do you think? Is she at risk of emergency hysterectomy? Yes, of course. Of course, she has a risk for emergency hysterectomy. Anyone know? No, 27. Sorry, give me a moment. She is at risk to have emergency hysterectomy, 27%. Okay, I'm not talking about cesarean section. No, I'm talking about emergency hysterectomy for this woman. She has a previous history of cesarean section. She's multiparous, and now she's having a placenta previa. Okay, next one is the incidence of vasa previa in a woman with IVF treatment. Forget about the number now. Why women with IVF treatment have a risk for vasa previa? Why do you think? Excellent, everyone. It's 1 in 300. Yes. But do you know why? Because they are more prone for placental abnormalities, like bilobed, for example, or abnormal insertion of the cord, right? So they are more prone for vasa previa. Okay. Yes, it's 1 in 300, as you all said, mashallah. What is the most common adverse obstetric problem in a pregnancy complicated by unexplained antepartum hemorrhage? And I'm giving you a hint, by the way. This question, if you don't know it, you are not going to answer it correctly. Because all of them can happen with antepartum hemorrhage as a complication, but he is asking about the most common one. Fetal growth restriction, of course, but it's not the most common one. Yes, oligohydramnios. And it's not expected, by the way. I'm not blaming you if you didn't expect it. This is one of the questions. If you don't know it, you are not going to answer it. This is an epidemiological study. They have found that oligohydramnios at the top of complication of any woman who have unexplained antepartum hemorrhage. Oligohydramnios. Then fetal growth restriction. Then preterm labor and CS. Then lastly is pre-labor rupture of membranes. Okay. I'm sorry for the cough. Okay. So remember it. It's not expected. Okay. Many of us will go for fetal growth restriction. Me personally, I will go for fetal growth restriction if I don't know this study. Okay. This is one of the most common questions of epidemiology that can come in the exam. The incidence of placenta accreta with previous history of placenta previa or previous history of cesarean section. Very, very, very important. So try to concentrate how much they are telling you in the history. Is it 1 previous cesarean birth, 2, 3, 4, and so on? Is it previous cesarean births or previous placenta previa? It will differ. It will differ in the risk. So here we are having 3 previous cesarean births. That means this woman would have 61% risk of placenta accreta. No more than 40%, 61%. 3, 11, 40, 61 fourths and fifths. I will give you the table. I will bring you the tables. Okay, this one. here. 5 or more. I'm not sure you can see it. Let me make a new share. You can see my screen now, right? This is the file I was talking to you about. The file of important figures in obstetric. 5 or more prior cesarean deliveries, the placenta accreta will be up to 67%. Okay. Two prior cesarean deliveries, 23 to 40. This is from the guideline itself. This is from the guideline itself, so I will depend on it. The answer in the power presentation is from the book. I'm not going to depend on it. I'm going to depend on the guideline itself. So the guideline itself say when it's 2 prior cesarean deliveries, 23 to 40%. 5 or more, 67%. No voice? Guys, can you hear me?
Clear.
Okay, thank you. Thank you so much. Okay, do you remember the last question of emergency cesarean section or and hysterectomy? This one will be very beneficial for you. Emergency hysterectomy can be up to 11% with a previous cesarean section. This risk increased to 27, like I told you, if she has previous cesarean section. If she has a previous cesarean section, it will be 27%. If she does not have previous cesarean section, it will be 11%. Another question. I'm trying to bring you placenta accreta. Yes, this one. This table, guys. This table is from Strategy website. Okay. So when you have 3 previous cesarean section, the incidence of placenta accreta is 61. 2 will be 40. This file is present in the general group. I can share it again. It's okay. It's shared for public. It's my collection, but it's okay. mrcog approved for the public share. I will share it again if you cannot find it. It's very, very, very important. Any digit that is in bold letters like this is very important in the exam. Okay. So again, let's get back to that question here. Forget about this. This is from the book. Okay, he answered correctly, but the explanation is not correct. So the answer is right, 61. 3 previous cesarean section, 61. Okay. This one. You are now preparing your patient for delivery, and she's having a low placenta, low-lying placenta previa, whatever. She had a recent blood sample sent to the lab for group and screen during the last admission. Within how many days should this sample have been sent to be used for the provision of blood? Yes, 3 days. If it's more than 3 days, then you have to take another sample. Excellent, inshallah. Okay, what about this one? And concentrate in the SBA, concentrate in every word, guys, every word. We're having C-section, multipara, central placenta. Okay, this one or the last one? This one, Dr. Ayat, or the last one? The 4 units? Oh, okay, the 3 days. Good, good, alhamdulillah. Okay, that's why I'm telling you, when you answer the most corrected books or the most recent ones, together with concentrating on the tricky points in the guideline, inshallah, you will be safe in the exam. Because common is common. Common is common. Don't go for or run after the rare questions among the groups. This is a waste of time. And please, please, I beg you, don't answer obstetric questions in complete recalls. It will give you headache and insecurity. Don't ever answer incomplete scenario. Excellent, everyone. Answer the question correctly. We need at least 4 units to be prepared. Excellent. For use in anticipation for intraoperative blood loss. There is another common question. When should we prepare ourselves for cell sulfage? When we are expecting how much of blood loss? In percentage, if you can know, because it's coming in the exam in percentage. Excellent. Yes. More than 1 liter or more than 20% of blood volume. If you are expecting the blood loss to be more than 20% or more than 1 liter, this is when you should be able to arrange quickly intraoperative cell salvage. Okay, excellent. Now we're talking. We are having a woman, 22 weeks. And write down your points, please. For answering a question for antepartum hemorrhage, I need to know where I am now, which gestational age I'm talking about now, what has been done, and I will start from the point the question is telling me. Okay, and I will give you an example later. So most of you agreed that she had her routine 20-week ultrasound. Yes, and it shows us that it has a placenta partially covering the cervical os. So I need to do another ultrasound at 32 weeks. Excellent, excellent, everyone. Okay, this is a correct answer. I'm going to ask you another question, just the same scenario, but with different options. Okay, so keep it in your mind. What about this one? 26 weeks, minimal painless bleeding following sexual intercourse. Before answering this question, guys, what is the first diagnosis or differential diagnosis that can come in your mind? When they told you that she's having a minimal painless bleeding following sexual intercourse. Forget about the options now. Excellent, everyone. Of course, E is the correct answer. Okay, I have got an answer B. And by the way, B is not incorrect. Okay, B is not incorrect. B is correct, but it's not the best answer. It's not the single best answer. You know why? Because The question asked me about which of the following confirm the diagnosis of placenta previa. Yes, excellent. It didn't tell me what is the initial investigation in such case. If I made a simple substitution in this case, what is the initial next step? What would be your answer, guys? What is the initial next step? Excellent. Speculum examination. If it was vaginal examination, would it be right? No. Excellent. When you have antepartum bleeding, spotting, any kind of vaginal bleeding, vaginal examination is obsolete. I should see the cervix and examine the vagina through speculum examination. Excellent. Okay, another question, because I have found some candidates have this concept in their mind, and I don't know why, but I think it's because of their facility practice. Is TVS contraindicated during vaginal bleeding? No. Excellent. It's not contraindicated. On the contrary, it is above the abdominal ultrasound. It is more sensitive than the abdominal ultrasound, and it should be the one used to confirm the diagnosis of placenta previa. Excellent. This is very important in EMQ. So take care. Ideally, you should know the right answer before going to the options. You should know the complete right answer for the scenario. This is the ideal situation. Then you will go through the options to search for your answer. You are going to find many similar answers in the EMQ in particular. So if you don't know the exact right answer, you are not going to answer the EMQ correctly. Excellent, mashallah. Okay, this one. See, I'm highlighting the keywords for myself to make sure I'm not missing anything. This is a major placenta previa at 32 weeks. So we have an established diagnosis for placenta previa. Okay, what else? The ultrasound scan shows an anterior placenta covering the internal os, okay, with irregular retroplacental sonulucent zone and hypervascularity in serosa bladder interface. What is the diagnosis? Someone tell me the diagnosis, please. Excellent. Not only a creta, this is per creta. This is per creta. It reaches the serosa of the bladder. Yes. So, okay, let's see what you want me to do. Fetal parameters are appropriate. Okay, alhamdulillah. She had her previous cesarean section for breech. Oh my God, she has a previous cesarean section also. Okay, that's why maybe she's having the percreta now. Okay, no any episodes of bleeding in this pregnancy. This is very important. This is very, very important. There is no episodes of bleeding until now. What is the most appropriate course of action? I got one answer. I need to know how do you think? Okay, so we have answers between C and E. We are now 32 weeks and we have Doppler ultrasound, okay? It shows us the vascularity and sonolucent zones and so on, okay? Okay, some of you have chosen MRI. When we choose MRI? You know when we choose MRI? When we don't have conclusive diagnosis for placenta previa or accreta or the accreta spectrum in general. Yes, when the ultrasound is not clear. When the ultrasound is not clear. Okay, Dr. Rania is saying we should repeat at 36 weeks for another TVS, as the GTG is saying. Yes, this is for placenta previa, but now we are talking for or about placenta accreta or percreta. That's why I asked you about the diagnosis in the very beginning. Okay? That's why the diagnosis in such cases is very important. Of course, this woman is going to have elective cesarean section. There is no doubt about it. Right? Okay. If there is any chance that there will be upward migration of placenta, no, we are talking about 32 weeks and above. This is established diagnosis for placenta accreta. What's done is done. Okay, so E is not correct. Okay. B is not correct because I'm having established diagnosis. I don't need the MRI. Immediate cesarean section? Of course not, because she is stable. Everything is good. Right? There is no fetal acidosis. There is no fetal hypoxia. So the best answer in this situation, or the most appropriate course, will be plan for elective cesarean at term with appropriate precaution for placenta accreta. Excellent. Okay, this one. I'm having a woman, 30 weeks, unprovoked, painless vaginal bleeding. At her 20-week scan, there was anterior low-lying placenta. I know now that 26% of the cases will be present with low-lying placenta. It's okay. It's okay. I'm not sure. I don't know if it's persistent or not. What else? Examination reveals the presence of cervical ectropion with minimal fresh bleeding. Can this be a cause for her painless vaginal bleeding? Yes, of course. She wishes to go home as she is reassured of the fetal heart rate on a CTG. Which of the following treatment options are best suited to her? I need you now to think about this case just like it's coming to you, and you are now RCOG candidate. So you are working according to the guideline. Okay, you are now ST3, ST4. So when you have a woman like this, the first thing you are going to do when you have painless vaginal bleeding, speculum examination. Speculum examination showed me cervical ectropion, right? Okay, but I'm having a history, or I'm having something that told me that she's having low-lying placenta at 20 weeks. So, excellent, everyone. I should do an ultrasound to check for persisting low-lying placenta, because this is a differential diagnosis for her bleeding. Excellent. Let's change it a little bit. If this line was omitted, okay, this line was not there, okay, and he is asking me what would be the best thing for her. Okay, I'm having different answers now. Okay, I'm going to ask you one question. Is the bleeding continuous or not? I'm now having a case of painless bleeding. That's why I wanted to omit this line, because I want you guys to think systematically. Think systematically. I'm having a woman with ongoing bleeding. She's having bleeding. Okay? It shows me ectropion. Okay, I'm now reassured somehow that this is the cause of bleeding. The first next step, or the best next step, or like they say, the following treatment best suited for her is to admit her to the maternity unit for observation until the bleeding stops. This is the next step. Okay? If it's continuous, I will order the ultrasound. Okay? Why I'm saying this? Because I know that most of you in your facility, you're having the ultrasound easily accessible. So the next thing that will come to your mind is order TVS. In the UK, this is not possible. The TVS needs referral, needs arrangement. Okay, guys? Urgent referral is within 2 weeks. Can you imagine? And when you have a continuous vaginal bleeding like this, or I don't know if it's continuous or not, they didn't tell me, but she has painless vaginal bleeding. Okay, I will admit her for observation until the bleeding stops. I'm having another scenario for this woman, so I don't wanna jump in scenarios. So let's see the other one. 30 weeks, first speculum, second ultrasound, third admission. Okay, systematically, again, I'm having a painless vaginal bleeding. Okay, antenatal painless vaginal bleeding. First thing, speculum, of course. Second thing, according to the speculum, if it's ongoing bleeding, I'm going to admit her in the maternity unit. Okay, if the bleeding is concealed or it has been stopped, so I'm going to order a TVS. You know now the difference? Yeah, it's like steps. Okay, I love this case. This is exact exam case. And this case shows us how to answer an EMQ. Candidates many times come to me and tell me the EMQ was very tricky. There was like 3 or more options correct. And I'm telling them, yeah, the 3 or more options are correct, but only one of them is accurate. This is the best example for this. The first one, we have a 32-year woman. Her detailed anatomy scan at 20 weeks of gestation show us that the placenta is situated posteriorly and it is suspected that the placental edge cover the internal os of the cervix. I need you guys to tell me how many options are correct. I don't need the accurate answer. I want you to tell me how many options are correct. She's now 32, she's now 20 weeks. Yes, exactly. Imaging at 32 weeks is correct. And transvaginal ultrasound scan is correct. So how I will make my mind? In one word. Okay, why you choose K? What is the difference between K and F? Both of them is TVS. Excellent, Dr. Sudha. Excellent. Detailed anatomy scan at 20 weeks, guys, is transabdominal. Mostly it's transabdominal, not TVS. So that's why I need now TVS to confirm that I'm having a low-lying placenta. Then, if it came out that I'm having a low-lying placenta now, I'm going to repeat the TVS again at 32 weeks. You got the idea of this one? The detailed anatomy scan is transabdominal, not transvaginal. So if you don't have this in your mind, automatically you are going to choose F and you are going to be very happy and I have answered every question correctly. And by the way, this is the type of question that I will never see in a recall. They are not going to recall it correctly. Every candidate will recall it the way he see it, right? So take care. Is transvaginal ultrasound has been done or not? Exactly. I will do TVS now. And if it's low-lying, I will do 32-week scan. But maybe when I do the TVS, I found the placental edge is more than 2 millimeter far from the cervical os. Right? TVS is very sensitive for placenta previa. Unlike placental abruption. Placental abruption, the ultrasound has no rule for diagnosing placental abruption. It's not sensitive at all. Okay, the next one. I think it's easy for you guys because mashallah you are very clever. This one, guys. Excellent, excellent, mashallah. This is the indication for an AMRI scan. Yes. Okay, last one. I said millimeter, centimeter, 2 centimeter. Excellent, guys. So you now see the difference. Yes. Excellent, everyone. Okay. Now we are having a case of antepartum hemorrhage. The diagnosis of placental abruption has been made. The bleeding settled with conservative management and she is discharged home. Can we do this? Can we do this with the placental abruption? Yes, we can. Yes, we can. If the case is stable and the bleeding stopped, she can go home. And we are going to give her the precautions and when to come back. So, what is the most appropriate plan for her further antenatal care? MashaAllah. See, we have D and E very close to each other, but E is more comprehensive, more accurate. Right? Excellent, everyone. So we are going to reclassify her as high risk, arrange consultant-led care, but she needs serial ultrasound fetal growth, of course. Excellent, everyone. Okay, I think this one is easy, but it's a chance to revise together the timing of delivery in different situations. We have here 2 previous cesarean section, color flow Doppler at 32 weeks, confirmed major placenta previa and placenta accreta. What would be the recommendation for delivery? Okay, I have some answers which say elective cesarean section at term. Take care, we are having placenta accreta here. We are having a placenta previa here. Placenta previa, guys, placenta previa, if it's not complicated, what is the best timing for elective cesarean section? Placenta previa. Let's revise together. The timing for placenta previa. This is one of the treasure boxes I think that I have shared in the general group. Uncomplicated. (36 to 37 weeks for the uncomplicated. Yes. Okay, so uncomplicated placenta previa, 36 to 37. Okay. I didn't say the answer yet. I didn't say anything. I'm just revising with you. Uncomplicated or asymptomatic placenta previa, 36 to 37 weeks. Okay, the mode of delivery, by the way, if it's just low-lying, not complete placenta previa, there is a room for vaginal delivery, but it should be the decision of a senior obstetrician. Okay, what about the complicated placenta previa? When should you deliver her? (34 to 36). 34 to 36. Why? Because they discovered that if you left her more than this, she will be prone for antepartum hemorrhage and postpartum hemorrhage and fetal risks. Okay, so I'm going to help you to remember it. the age of best viability is 34 weeks. Okay, that's why you are going to find 34 weeks in many situations, like twins, for example, like complicated placenta previa. I want to push this pregnancy until 34 weeks. I will push it as much as I can until 34 weeks. Okay? This will give me a chance to give her corticosteroids for more fetal lung maturity and so on. When it's uncomplicated, maximum 37 weeks. Maximum. More than this, she will be prone for maternal and fetal adverse outcome. Okay, for Akrita alone, I should plan the delivery maximum by 36 weeks, 35 to 36. 35 to 36. So the best option here will be B, elective cesarean section at 36, 37 weeks. Okay? For elective cesarean section in a normal pregnancy, uncomplicated normal pregnancy, what would be the gestational age for delivery? Yes, excellent, excellent, everyone. 39, 39, not before 39. To be specific, not before 39. Excellent. Does she need I cannot stop myself. Does she need antenatal corticosteroids? She are going to have an elective cesarean section for normal low risk pregnancy? No. Excellent, everyone. No, she does not need. Okay. Okay, this one is good. A prima gravida is seen in the antenatal care clinic. A routine mid-trimester anomaly scan at 20 weeks reveals placenta previa. We know now up to 26% will have this. I should put this in the first part of this presentation. Now you know that I should arrange a transvaginal scan immediately to reclassify her. Yes, excellent. Okay. Now, if I'm having an anterior placenta with a multipara and she has 2 previous cesarean sections, what do you think, guys? Should I choose D, TVS at 32 weeks? What I'm afraid of in this case, what I'm afraid of? Accreta, excellent. And placenta accreta is not going to be diagnosed with a normal TVS. There should be a color flow Doppler. Remember the scenario with the translucency behind the placenta and hypervascularity of the placenta that reached the bladder serosa and so on? Color Doppler is a must, is a must. TVS is a grayscale scan. This is the normal TVS. Okay? It can show you that there is minimal amount of myometrium behind the placenta. Okay? We used to do this all the time. But this is a suspicion, not a definite diagnosis. Okay? To diagnose accreta, you should have a Doppler, especially when you have a previous cesarean section. Because most commonly, the placenta will will be adherent to the previous scar, and the previous scar is very thin. So the possibility of accreta is more. Just doing a TVS for a previous cesarean section multipara is not going to give you a definite diagnosis, because most of the cases you are going to see a placenta that is invading most of the myometrium. Now I'm not sure. Is it increta? Is it accreta? Is it percreta? I'm not sure. You got what I mean, Dr. Muhammad? The invasion of the placenta does not appear sensitively speaking with the normal gray scale scan. So this is a rule. This is a rule in our guideline. When you have a previous cesarean section and you are now suspecting a placenta previa, the next scan at 32 weeks is not going to be a TVS only. No, it's going to be a color flow Doppler scan. Color flow Doppler scan means TVS plus Doppler. Okay, both of them. Okay. What is the usual method of diagnosis? Placental abruption. Excellent, guys. Clinical diagnosis. Never ever depend on transvaginal ultrasound. It makes me feel really, really sad. Is a very small word. When I found an intern order a TVS for a suspected placental abruption, what are you doing? Really, what are you doing? Are you expecting to see retroplacental hemorrhage? Are you expecting to see the hematoma concise or calcified? This is nonsense. Okay, clinical diagnosis is your key. Okay, so because you have chosen A, someone tell me what are the signs of placental abruption? Okay, I'm having woody tender uterus. Excellent. Painful vaginal bleeding. Okay. Tender abdomen. Abnormal CTG. Abnormal CTG is an advanced step. But if I'm having obvious abruption, it will be hard, tender, woody uterus. Yes. With painful vaginal bleeding. This is a sign and symptom. Okay. But sometimes, for some cases, rare cases, we have something called concealed abruption. Excellent, Dr. Khadija. This is very important. The risk factor, the history. This is your key to diagnose concealed abruption. You know what is concealed abruption? Yes, when there is no bleeding. Excellent. There is no vaginal bleeding. So I will depend mainly on the history, right? Mainly on the history and on the tender abdomen and on the abnormal CTG, mainly. Then the ultrasound can give me a sign of retroplacental hemorrhage, for example. But it is limited also, it has limited sensitivity. Those cases are very, very challenging. Very, very challenging. And usually they are late diagnosed. Are going to diagnose them from the general situation, from the general clinical examination of the mother, her clinical condition. She is going to develop hypertension. She's going to develop severe declining of hemoglobin because there is ongoing bleeding. So you are mainly going to depend on clinical situation plus the history. If she is high risk, if she's high risk, but not every woman with tender abdomen, right, and anemia, for example, I'm going to suspect placental abruption. So let's talk systematically. I'm having now a woman with tender abdomen, okay, and minimal vaginal or no visible vaginal bleeding. What should I do first? 1, 2, 3. First thing is what? Ultrasound. Check fetal heart. Admission. Yes, Dr. Salma is going very basically. Dr. Raja is more accurate. Excellent vital signs, guys. A, B, C. A, B, C. This was a trick question, but you know, it can come in the exam, and it came. A, B, C. When you are having a suspect, this woman is now, look, you are all now thinking about placental abruption and placenta previa. But you forgot that this is an acute abdomen. This is a case of acute abdomen, right? So ABC, maybe this tender abdomen has nothing to do with the uterus. Maybe it's appendicitis. Maybe it's torsion. Maybe it's uterine rupture. There are several differential diagnoses for this tender abdomen. So deal with this case as acute abdomen. Don't think about specific diagnosis. ABC, airway, breathing, circulation. Everything is okay. So what about the vital signs? Is she hypotensive? What about the hemoglobin? It declining? Is she anemic? Does she have high risk for uterine rupture or placental abruption? Where is the site of pain? Where is the pain referred? Is it acute? Is it chronic? Is it intermittent? Right? So, by the way, this will happen in the exam. You are going to have a question like this, talking about placental abruption, for example. So your brain now is systemized to answer the next question for placental abruption. So when you have a question for acute abdomen, what your brain is thinking about is placenta previa and placental abruption. Don't do this. Okay? Deal with the case as a different patient. This is now a different patient coming to me in the ER, complaining of tender abdomen or acute abdomen. So I'm going to deal with her as a case of acute abdomen. Okay. What about this one? This is a type of question that if you don't know what to do, you're not going to answer it correctly, according to the guideline I'm talking about. If you don't know what to do in cases of low-lying placenta or placenta previa, and she has consented previously for sterilization, okay, what should I do? I'm having A, I'm having B. I need to know how you are thinking, guys. Okay, so most of you agree on B, elective cesarean hysterectomy. Because, as Dr. Muhammad is saying, she has consented for sterilization. Okay, why not A? Why not A? Why not C? Dr. Rania, for example, said C. That's why I'm telling you, if you don't know the answer according to the guideline for this question, you are going to have many correct answers. Actually, A can be done, B can be done, C can be done. Okay, but the best thing, evidence-based speaking, is B, elective cesarean hysterectomy. Why? Yes, excellent. Because any attempt to separate the placenta, heroic attempt, I'm going to name it heroic attempt, is going to cause massive bleeding. And they have discovered that this will cause short-term morbidity. DIC, massive blood transfusion, urological injury, and so on. So elective cesarean hysterectomy in such case is the best, especially that the women have already consented for sterilization. So they made it easy for us. They made it very easy for us. You know, if this patient has refused to consent for sterilization, I would warn her, ma'am, you are going to be at risk for coagulopathy, ICU admission, laparotomy, urgent hysterectomy or emergency hysterectomy if we fail to manage your bleeding. Are you okay with this? Yes, I'm okay, but I don't want to lose my uterus. I need to have another children. If you can save my uterus, please do it. Then you are going to attempt to separate placenta. And by the way, I know doctors who do this type of operations. They are specialists for removal of placenta accreta and placenta increta or percreta. Also, they are specialists for this. They spend their lives for those cases only, okay, without hysterectomy. This needs very senior, not senior, very senior obstetrician. This patient came as emergency and she is under general anesthesia, and they didn't mention what kind of sterilization. Just the word sterilization means that her family is complete. Just the word sterilization. That means that she is okay with hysterectomy. It's not a must that he will tell you what kind of sterilization. Okay? Elective means it's not emergency. Means I'm going to prepare myself way before 36 weeks to deliver this patient. I'm preparing myself, I'm preparing the blood units, I'm preparing cell salvage, I'm correcting her anemia, I'm having a specialist team in placenta previa, specialist nurse for placenta previa. That's what elective means. Emergency cesarean hysterectomy is when you are having a case of postpartum hemorrhage for whatever reason, you are having a postpartum hemorrhage now, and it's uncontrolled. Yes, she came in labor. Okay, this is emergency cesarean section before. Oh, I got what you mean. I got what you mean. Yes. صدق والله لسه واخده بالي من الموضوع ده. Oh, okay. I got the point. Okay. It's called elective here. Yeah, because I'm sick. It's called elective here because she is not having postpartum hemorrhage. This is not a rescuing cesarean hysterectomy. Okay? This is just because the placenta fails to separate. Okay, that's why the author wrote it elective cesarean hysterectomy. Yes, the same case, guys, the same case. If the woman didn't consent for sterilization, or if he mentioned by any means that this woman family is not complete, that means I'm not going to do elective hysterectomy. I'm going to choose A. What if this patient is having now postpartum hemorrhage or ongoing bleeding? What would be the best accurate answer for this question? Ongoing bleeding or postpartum hemorrhage, or she has lost more than 1 liter of her blood, or she every conservative measure for the control of postpartum hemorrhage has failed. The best answer for this situation now will be emergency cesarean hysterectomy. Excellent. So now you got the difference? Okay, alhamdulillah. I think we have reached the end. Thank you guys so much for being here today. I'm so happy you replied our invitation. Inshallah, we are going to do much of these sessions, inshallah. I thought 1 hour is really nice. It's really nice. So I can do it more and more, inshallah. If you have a particular topic that you feel conflicting, share it in the general group so I can prepare a presentation like this. Okay, thank you so much. The next one will be, if I have time, it will be this week, by the end of this week. If I don't have time, it will be next Sunday, same timing, inshallah. But I will try to have one by Thursday, maybe. Inshallah, I will tell you. Thank you guys so much. Stay soon, inshallah. Take care.